Okay, welcome everyone. We're so glad that you are here to listen in on our webinar today about dual diagnosis. We have a great team with us. We're going to be talking a lot about what exactly is dual diagnosis between developmental disabilities and behavioral health concerns. What does that mean and what does it mean for you? And so we've got a great team of experts that are the hub team of the MOADD ECHO. MOADD ECHO stands for Missouri Alliance for Dual Diagnosis, and a lot of folks around the state have been working really hard to make sure that we have a plan in place to help serve individuals who have a dual diagnosis and also serve them better. So without further ado, we're going to get started. I'm Kristen Soul. I'm a pediatrician at the University of Missouri, and I'm also the founder and executive director of ECHO Autism. And really all we're about is making sure that people have access to best practices no matter where they are, whether that's in a rural community, an urban community, all around the world, wherever they are, having access to best practices. Today, we're going to again talk a lot about dual diagnosis and what exactly that means. What we find is that there are often a lot of myths around what dual diagnosis is. And so we're going to try to dispel some of those myths and help to really bring to light what's going on. So I'm going to introduce the crew. First, we have Shauna Shelton. She is a nurse clinician for the University of Missouri Thompson Center for Autism and Neurodevelopmental Disorders. She works closely with patients and their families to educate and ensure proper care and management of common medical and psychiatric conditions in patients, particularly with autism, but lots and lots of other developmental disabilities, as well as mental health diagnoses. She serves on the MOADD ECHO Hub team as the medical specialist. Rachel Jones is the manager of trauma-informed care with the Missouri Department of Mental Health, the Division of Behavioral Health. She's a licensed professional counselor, and her role is to provide assistance with various projects to further implement trauma-informed knowledge, practices, and treatment across the state. She serves on the MOADD ECHO Hub team as the trauma-informed specialist. Next, we have a dear friend, Dr. John Constantino. He is the Blanche F. Idelson Professor of Psychiatry and Pediatrics at the Washington University in St. Louis, where he directs the William Greenfeld Elliott Division of Child Psychiatry. He also directs the NICHD Intellectual and Developmental Disabilities Research Center and serves as psychiatrist in chief at St. Louis Children's Hospital. John serves on the MOADD ECHO Hub team as the child and adolescent psychiatrist. Susie Henderson is a licensed psychologist with 40 years of experience in providing mental health services to adults, children, and families, including in this experience, is working with individuals with autism spectrum disorder, as well as other developmental disabilities. She is the vice president of special projects for Burrell Behavioral Health in Springfield, Missouri, and she serves on the MOADD Hub team as the mental health specialist. We've got a couple of other important folks on this crew, and so I want to make sure that they get a shout out as well. And so Amber Stockreef is a board certified behavior analyst, and she serves as the Interdisciplinary Children's Services Coordinator for the Missouri Department of Mental Health, Division of Behavioral Health and Developmental Disabilities. She has lots of experience in this space between dual diagnosis or around dual diagnosis, and she serves on the MOADD ECHO as the clinical system navigator. We all know what a system this can be to navigate, and so we're very thankful for having that expertise. And then Dr. Terry Rogers is the former chief behavior analyst for the Missouri Department of Mental Health. She has over 30 years of experience as a practitioner of applied behavioral analysis. She provided behavioral services in a wide variety of settings and has participated in research and published in areas of self-injurious behavior, parent training, and severe behaviors. Her proudest work has been in helping to develop the caregiver curriculum called the Tools for Positive Behavior Change, and in leading and working with the behavior analyst team at the Missouri Division of Developmental Disabilities. So certainly we are so thankful to have them. And then that last, but absolutely not least, is something that we're always proud to have as a person with lived experience on our hub teams. And so Lisa Nothouse is the supporting families lead for the Missouri Department of Mental Health, the Division of Developmental Disabilities. Her primary role is to help families access resources. She's been involved in the developmental disabilities field for over 30 years, and she serves on the hub team as the family advocate. Again, you can have as many experts as you want all lined up, but if you don't have somebody who's actually lived it, it doesn't often go as well as when you have someone who's either a self-advocate, someone with individualized learned experience or lived experience, but absolutely a caregiver, really walked through this journey with their family. And so we're so thankful to have Lisa as part of this amazing team. All right, we're going to get started with our content. Again, we're going to be talking about dual diagnosis, mythbusters, and modifications, and I'm going to turn it over to the team to start sharing that content.
Thank you. Hi, everyone. I'm Rachel Jones, so I'm going to be presenting the information today, and I'm really excited to have a robust discussion about understanding the dual diagnosis of developmental and behavioral health conditions. We're going to explore the myths that surround the topic that tend to get in the way of how we view and understand co-occurring conditions. We're also going to spend some time with modifications for treatment so we can reach the population in meaningful ways that promote recovery, rehabilitation, and really improve overall quality of life. MOADD has been working to shift our thinking about the approach that we use to treat dual diagnosis. The old approach is an all or nothing strategy where we try to fit people into one or the other. And sometimes we argue about who should be taking the lead, what's the most prevalent condition, or what needs to be done first before another aspect of the individual's life can be addressed. The billing structure, eligibility criteria, programs and services are often kind of structured around that old approach, which assumed that people's lives weren't interconnected and it was a siloed approach. But we're moving toward a trauma-informed approach that's much more integrated and overlapped. This perspective is that people with dual diagnosis have unclear and complicated needs that are usually a mix of a few things put together and evolving and changing over time, which is why we also need an interdisciplinary approach to care and treatment. It considers trauma and trauma-informed principles at the center of it all. And although trauma is not evident or impacting every dual diagnosis case, research does show that people with dual diagnosis are more likely to experience trauma. And the helping professionals who are serving them are also impacted by trauma in their personal and professional life. So this is what's been guiding a lot of the work that we do at MOADD and how we're viewing cases, problems, and solutions, how we're asking questions, trying to understand other disciplines, their terms, their acronyms, their services, and their limitations. And it's how we're trying to adjust our system to better serve individuals who are impacted by these overlapping conditions and diagnoses. So it's in that spirit that we want to spend some time challenging the myths about treating people with dual diagnosis and co-occurring developmental and behavioral health conditions. So here are the top 10 myths about dual diagnosis. Myth 1, individuals with intellectual and developmental disabilities cannot engage in treatment. The fact is they can engage in treatment, but sometimes it needs to be adapted or modified. And we're going to talk about that more a little later. Myth number 2, behavior modification is the only treatment option for people with intellectual or developmental disabilities. It assumes that the only way that you can help them is if you try to control, reward, or discipline behavior choices. When in fact, individuals with intellectual and developmental disabilities and their families can engage in other types of treatment to assist them with recovery from past or current trauma or from other problems that they're experiencing. So it can be more than just modifying behavior, but actually working on issues of sadness, grief, rejection or betrayal, or existential crisis that also impacts their life. Myth number 3, behavior modification is the prevalent behavioral approach for people with IDD, and it only focuses on punishment and extrinsic motivation. So in other words, they only make the change because they're going to get something out of it or they're trying to avoid punishment. The fact that challenges this myth is that positive behavioral supports is the current best practice, and it focuses on helping people meet their goals through skills-based teaching and increasing intrinsic motivation, which basically means that they can change their behavior just for the sake of doing it or because of a personal rewarding feeling that they'll get from it. Myth number 4, individuals with intellectual or developmental disabilities do not experience trauma or remember it. Unfortunately, the facts here have been well researched, and people with IDD are 2 to 4 times more likely to experience various traumas because of additional vulnerabilities. These include physical, sexual, and financial abuse, exploitation, bullying, domestic violence, among others. So they can remember trauma, and they do remember it. Sometimes they even try to tell people about it, or the person caring for them may be a perpetrator and they don't know how to tell people about it. Sometimes they retell or re-experience, which can make it challenging for their treatment team to try to figure out, is this something that's historical? Is it current? Did it happen just once? Is it ongoing? But oftentimes, unfortunately, the issue of trauma is overlooked altogether because families and providers tend to focus more on the behavioral problem that is being reported or the diagnosis itself, whether developmental or behavioral diagnosis. Now, myth number 5 is closely related to the last one. Since people with intellectual and developmental disabilities don't talk about their trauma, it probably isn't something we need to address. Fact, the experience of trauma occurs completely separate from the development of language. So here are 2 examples of what I mean. A 1-year-old child can experience a significant trauma, but they're pre-verbal and they can't tell anyone about it. Just because they can't tell anyone what happened doesn't mean that what happened didn't impact them or won't have more long-term impact on their physical health, their mental and social emotional health as they get older. Another example is a person who experiences trauma but speaks another language that you can't understand. If they're trying to tell you about a trauma and you can't understand what they're saying, it doesn't mean they didn't experience the trauma. It just means their communication barrier is there. And that's a separate issue from what they experienced and may still be experiencing and influencing their life, their health, and their relationships. Myth number 6, individuals with trauma exposure or mental health concerns can't benefit from PBS strategies. The myth here is that PBS is only for intellectual and developmental disabilities, and it can't be incorporated into other aspects of a person's care, like addressing mental health or trauma recovery. When in fact, PBS parallels trauma-informed principles very well and could be combined with therapeutic techniques that could accelerate treatment and yield more positive outcomes. PBS strategies are used in school systems and can be applied in other settings as well. Myth number 7. This is the idea that challenging behaviors are due to a person's diagnosis. But when you think about it, there are a lot of reasons why people might have behavioral problems. Uncomfortable medical conditions that are mood altering, scary, or confusing, maybe because of medications or other health complications. It could be from pain or depression and anxiety, and of course, trauma. Or it might just be because they don't have the skills they need to do things on their own, or they're not being understood by others, or because of things that are going on in their home or community environments that's impacting them. The environment piece is especially important to note with children who have dual conditions, because they function within 2 larger systems, home and school. Environmental stressors and adverse childhood experiences have significant impacts on them as children, but also the ACEs research shows us that the long-term negative chronic health problems can occur later in life. 8 out of 10 of our most chronic health conditions today can be traced back to adverse childhood experiences and environmental stressors that were happening in the home or the school or community. So when we're working with the complexities of dual diagnosis and co-occurring conditions, we really have to take a holistic, environmental, and interdisciplinary approach to try to figure it all out and work together to find solutions. Myth number 8. Therapists are the only ones who can work with an individual's trauma. Fact, you don't have to be a therapist to be therapeutic. There are many examples of people in a person's life that provide them support, help, resources, and nurturing care that is extremely therapeutic. We need to keep an open mind about all the ways that a person can get therapeutic experiences and not assume that it only comes from a specialist. Myth number 9, therapy can only be done with someone who has the ability to verbally communicate. The fact of the matter is that therapists can use other skills besides active listening, which requires a person to be talking. So those skills can include things like observing the client's behavior, reflecting a client's actions, noticing their mannerisms and facial expressions, and paying attention to noticeable shifts or changes and tone. Relying on other forms of communication besides just verbal is so critical with the dual diagnosis population. And that doesn't just apply to therapists. All providers on their care teams can use these other communication strategies to better understand their needs. And now we're at the end of our myth list with myth number 10. PBS strategies only work with people who have limited language skills. Actually, PBS and ABA-based strategies can work across all kinds of populations and the spectrum of the human experience. So those are our 10 mythbusters. What'd you think? To unlearn what we've been taught, we have to actively challenge the myths that pop up on a regular basis because they're so deeply ingrained, not just in individual people who might believe the myth, but within our professions and disciplines. So now that we've busted our 10 myths, let's move on to talking about modifications for treatment. It's possible to provide therapeutic support for people with developmental and behavioral health conditions. Many good therapeutic interventions can be modified and adapted. Typically, you want to use approaches that work for other people in the same IQ and functional level or range. If you're using interventions that are geared for someone who functions higher than the person you're serving or lower than the person you're serving, then you often find conflict. The provider or direct care support staff may get frustrated or feel overwhelmed and annoyed that things aren't working. They may have unrealistic expectations of what a person could or should remember or do. The person that you're serving may feel disempowered, patronized, or incapable of making change. And this can have obvious negative impacts on their care and treatment. All of this together can lead to provider burnout and no longer believing that a person is able to grow and learn, and that influences their overall quality of life. So a combination of bottom-up and top-down approaches can be effective. Let's look at this a little closer. When we use a trauma lens and we understand how stress and trauma impacts the brain and body, we can appreciate the role of bottom-up approaches to help regulate the nervous system and give people skills to self-soothe. This comforts and stabilizes people, and it gets them in touch with their body awareness. It calms and promotes safety and trust, and it involves sensory motor techniques. And we'll go into those in a little more detail in the next slide. Now, the top-down approach has historically focused on the 50-minute hour, sitting in a therapist's office for a scheduled appointment, where the goals are to talk and listen and to make meaning of situations, to change narratives, to be more helpful. The top-down approach relies heavily on whether a person can verbally communicate and comprehend what's being said, and if they can learn and demonstrate coping skills. Either or both of these approaches can be used when you're working with dual diagnosis cases. In general, we really don't blend them as well as we could. If we did, we might notice improved health conditions, less frequent outbursts and incidents, and more engagement in care from both a provider and a client's perspective. So let's get a little more specific about how to use sensory motor techniques to help a person regulate their nervous system. It might actually be helpful to just take a moment to reflect on how this impacts you, because this is an aspect of the brain-body connection that influences everyone, not just those with dual diagnosis or co-occurring condition, but think back to a time recently when you might have gotten upset about something. Maybe you felt tense or angry, or maybe you lashed out at someone or felt really distracted. Your nervous system was activated, and it may have even been in overdrive. Now, imagine that in that moment when you were upset, Someone wanted you to sit down and talk about your problems and goals and dreams and coping skills. You probably couldn't even get into the headspace to do that until you were able to calm down first. And that's the survival brain, thinking brain dynamic. That's the sympathetic, parasympathetic nervous system interacting with each other. So we can use these strategies to help regulate the nervous system and calm people down, which changes their mood and their energy. And it also helps the organs and bodily systems get to an equilibrium. So it's not just about how a person thinks and feels. It's also about lowering their heart rate, changing the blood pressure, getting more oxygen to the brain, improving circulation, and re-engaging other systems that went offline so that their vital organs can function more normally. And this is a really important thing for people who have dual diagnosis because they might also have complicating health conditions too. So the good news is you can teach people how to do these things for themselves. Breathing is the easiest way to promote rest, relax, and recharge and kind of get that oxygen flowing to the brain and the body. Mindfulness and reflections help people move away from what has happened or what they're worried will happen to focus on what is happening. It changes the chemistry of the brain, which sends signals out to the rest of the body. Using the 5 senses is a wonderful way to promote body awareness. Grounding exercises or sensory toys and tools are helpful. Tight hugs, weighted blankets, aromatherapy, fidget toys. Those are some specific examples of how you engage the 5 senses. Movement that promotes bilateral stimulation of the right and left brain is also really great for recovery. And much of the time, these activities don't even feel therapeutic. They can be really fun and expressive and artistic, and they can be based around what a person's hobbies and interests are and things that they really enjoy, which also makes a huge difference in their overall quality of life when they engage in these bottom-up techniques. But now let's look at some strategies to adapt or modify the top-down approaches that rely more on a person's ability to communicate and understand what's being asked of them. It should always, always, always start with strengths. Everyone has strengths, no matter their dual diagnosis condition, their behavior challenges, their experience with healthcare or with social services, they still have strengths. Learning ways to adapt and modify is a really great opportunity for interdisciplinary collaboration. So for example, behavioral analysis or behavioral analysts are trained to teach non-standard learners. So other professionals can help us understand ways to approach things and find more success. Now, we created this do this, not this list, and you'll notice there are tips to use short statements, common terms, break things down into smaller, more attainable steps. Slow down and chunk and check. And that means you break down the information into bite-sized chunks, and then you check to see if they understand before moving on. You'll also need to repeat information often. You may have to change your expectation that they'll be able to learn it once, remember it, and apply it later. Most people don't really learn that way. Incremental and repetitive approaches usually work better for learning and being able to apply skills later. Use unconditional positive praise and reflect what you see or hear them doing and saying. You'll need to do that more often because withholding praise and attention until they master something, that can be very discouraging, and they may not get it right or get it right away. They still deserve praise and encouragement. And visual aids and role-playing different skills can be helpful ways to teach. Shorter, more frequent sessions instead of those traditional longer weekly or every other week sessions are usually more successful as well. So I hope you found this information helpful and understand a little bit more about the complexities around dual diagnosis of developmental and behavioral health conditions. We want to encourage you to keep learning. So please download our MOADD app. It's a decision-making guide where you can get a lot of wonderful information about several common conditions and challenges, trauma-informed best practices, evidence-based strategies, and we've even included some vignettes to help you consider ways that you might apply the information to cases that you're already working on or that are familiar. So now I'm going to turn things back over to my MOADD colleagues for the Q&A portion of our Take Action webinar.
Excellent. That was so helpful. I learned a lot in that, Rachel. So thank you so much for your expertise. So I definitely have questions, right? I can imagine, you've heard I'm a clinician as well, but certainly anytime that I'm thinking about complex dual diagnosis or even just regular dual diagnosis, right? Because it doesn't always have to be complex. It's thinking about where do I start? So let's for a minute just put on the hat of a person who's out in Missouri someplace. Let's say it's in maybe a little bit more of a rural location, and they go to their doctor, and it's their regular doctor, maybe let's say a family physician or a pediatrician. What do you guys think? And we can start first with Rachel, but really can be to anybody. What would be a resource, so to speak, that clinician, that physician or nurse practitioner could go to kind of get started with this family that just walked into their office? So who wants to take that one? We can start with Rachel, like I said, but we can also certainly, I'm happy to have Amber or anybody else who wants to share what their thoughts are with that.
Knowing websites and like state resources and things like that. So being able to access that frequently, usually we have that pretty well updated as far as webinars and things like that to access information and other resources. I know that's a lot on the clinician to go like out and research. I was also thinking too, just trying to connect with local community resources. So if you know there's a community mental health center in your area, trying to contact the director there and talk to them and say like, so how do I send my clients to you? Same way with our regional office, trying to do that as well. Because the more you have those connections locally, I think the easier it is to kind of refer clients and get to know what those practices and what that looks like to access services. So.
Great, thank you. And I think John's going to go.
Yeah, I would just add that on the DMH website, there is a page for MOADD. On that page are the QR codes to get access to the app that Rachel just talked about for clinical decision support, and for everybody who's invested in the care of a person with dual diagnosis can access for free and get the universe of information that is actually available on that app for understanding what's possible to help in the care and ongoing treatment for an individual who has dual diagnosis.
Awesome. And just in case, if you're listening to this webinar or if you're wanting to learn more, you can go to dmh.mo.gov, and then you'll kind of navigate through to the MOADD page. So for those of you who like to Google like me, I just typed in Missouri, DMH, MOADD, and there you got it. And so that way it's a good, quick way to get there. Because I know when you're busy and you're in clinic and you're sitting in front of a person that has maybe some behaviors that you're not as familiar with, it can be kind of overwhelming. And so having that quick access to something, I think can be really, really helpful. So thanks, John and Amber, those were really helpful. So thinking about it from a family's perspective. So Lisa, I want to hear from your perspective. What are some resources that families could maybe turn to? So let's say maybe they haven't managed to get to the doctor yet, or they're starting to get concerned that there's something going on that they need extra help with. What would you suggest to them?
Well, because I am a family member, I can throw my personal perspective in here too. And knowing that there's a multitude of information and resources that can be beneficial at any given point in time, it really depends on where that family is in their journey as to what specific resource you might share with them. But in general, there are three basic types that always come to my mind. It's general information and resources, which can include information about a child's diagnosis, about treatment options, about what's available in the community, about what they need to know and do to help their child be successful at home or in school. And there's also peer support that always comes to my mind. And I think that's one of the really important connections that I've made in my life, is to another family member, somebody else who's walking that same journey and can share those experiences. And that really helps, almost like what Rachel referred to earlier, that not everybody has to be a therapist, right? So there's therapeutic value to talking to other folks who have been in that same situation, or somebody that's been there, done that, and can kind of help guide you through maybe what some of your next steps would be. And then I always think of the tangible type of supports and services. It's easy to tell somebody what they need to do, but then we also need to back it up with where they can go get it. So the information about the tangible supports and services, so whether it's therapy, counseling, medical services, they need to know where they can go in their community. So those are the three basic things that usually come to my mind when I'm thinking about supports and services, resources for families.
That's awesome. Thanks so much, Lisa.
Kristen, could I just add one thing about that?
Yeah,
One of the elephants in the room for families, that, as Lisa was referring to, is that sometimes patients with dual diagnosis get pigeonholed into one category of service or another. They're either in a system for people with developmental disabilities, or they're in a system for people with behavioral issues or impairments. And oftentimes those two worlds are very, very different in terms of what they're offering, what the people that are engaged know, and are often thinking about it in terms of whether they had one or the other. And sometimes patients with dual diagnosis never get access to what really could be helping them across both domains.
Agree. And I think that's an important piece to think about too. And that actually leads me into another question that we're going to stick with Lisa on for a second. So Lisa, when you're thinking about, and you mentioned like the peer support kind of side of things, but how would you describe or share with us a little bit about how dual diagnosis, for example, impacts the family emotionally, right? We know obviously the person with those diagnoses may be experiencing things, but talk to us a little bit about the family and what that perspective feels like and looks like.
Well, I would say the easiest way to describe that, it's kind of like a roller coaster sometimes. It almost doesn't ever stop, right? So you've got negative and positive emotions that are happening all the time. And I think it's important to think about and remember that as that child has received a diagnosis, whether developmental or behavioral, the family also just got a diagnosis as well. So I automatically became an advocate, a caregiver, a coordinator, and whatever else my daughter needed at the time. And it's going to apply for life potentially. So it's not something that's really just here you go and it's gone. It could be for the rest of their life or my life. So that's a lot of extra to put on the plate when you're just getting ready to be a mom or a dad and embark on building your family. And now you have a child that has a diagnosis that brings all the extra stuff to it. And I think about the grief cycle, and I can honestly say this from my perspective, that is something that I am on and off on a regular basis. And it might be in one day's time, it might be over several months, but constantly going through that cycle is something that we go over and over for a variety of reasons. So I think other families are doing probably the same thing. Relationships change. You have that emotional aspect. When you have the added stress in your family, I'm not just talking spousal, we're talking relationships with all family members, your grandparents. There can be some conflicts there. There can be relationship problems with the siblings in the home. And sadly, there's a lot of times when families will navigate away from the friends that they may have had for many years because there's a difference in opinion or the focus just changes. So sometimes you find families are in isolated modes, depressed, experiencing some rough patches. So the emotional aspect is very important to consider. And I think about just participating on this hub and in these echo calls that we've had is trying to think about what that family's bringing to the picture, not knowing where they are on that grief cycle. If they're coming to us and an appointment, they might have just gotten some really rough news. They're not ready to absorb everything that we're sharing with them. So it might be something that we have to do that continually and keeping check with where they are on that cycle. Helping them get the support that they need. I know that's important, but I also know I've talked to many, many moms. We know we need that break, but taking the break, you also feel guilty. So it's a constant struggle sometimes, a pull and a tug. And that kind of goes back to the peer support that we talked about. Having somebody like that to talk to that can relieve a lot of stress in a short period of time, and most and oftentimes at no cost. So making those kinds of connections is very important. And I think, as we know, the emotional support, if mom is not happy, a lot of folks aren't happy in the family. So if it impacts one person, it impacts the entire family unit.
Yeah, absolutely. Thank you so much. And very, very well said. And I think that goes so much to this notion of whole care for the whole person and the whole family, right? And I think that you really highlighted some important pieces to that journey that so many families are on. And yet sometimes clinicians forget to check in with the parent, or to remember that those same principles that Rachel so well put, as far as working with people with dual diagnosis and helping them to understand, also can be pretty useful for the caregivers and the loved ones of people with dual diagnosis too. So thank you so much for that. So thinking about clinicians, for example, I think that Shauna brings to the table this amazing blend. She not only gets to talk to so many families, similar to what you were just describing, Lisa, but also really then translate that over into the clinical side of things. And so Shauna, I'm curious, would you help us understand kind of what some common symptoms are or issues that parents or caregivers may bring to you and they share with you the most?
Yeah, I love what Dr. Constantino said about we kind of box these people up into mental health disorders and developmental disabilities. And I think it's really important. And you just said it, whole person. You have to look at the whole person. And in nursing school, we were taught head to toe assessments. And as a nurse clinician, we do a lot of that. Okay, there's lots of comorbidities that go along with both these diagnoses for families. Some are medical-based comorbidities, some are mental-based comorbidities. And it's really important to make sure that when you have a patient, you look at both of those. You might not have expertise in both areas, but you can ask questions. And so when families call, if their child has autism and aggression, but they also have anxiety and depression, and they're having sleep concerns, what is causing what? It's very important to kind of figure out what is leading to what. And we have a lot of conversations about that. Just because they have a diagnosis of autism doesn't mean their aggression is because of that diagnosis. It could be related to lack of sleep at night, constipation, a situation in a school environment where the child is being picked on. You have to take this all-encompassing look at every environment with every patient. So home, school, church, anything that's part of that child's life, you just really have to keep that in mind when you're doing, having those conversations with families. And a lot of our families will say, oh gosh, I never thought about that, or I've never asked the teacher what's going on in school. And I think it's just important as the provider or the therapist or something to kind of always have those in mind to help the family kind of visualize the whole day for this person, to make sure we're not missing something, that if there's a language component and they can't tell us, that they situationally, we might be able to figure out just through some investigation, what is the cause of their current symptom or concern.
Excellent. Thank you. That's super helpful. And I think when I think about looking at things through that whole person perspective or that whole family perspective, obviously not every clinician is going to know quite all the different things to ask and how to do all of that. And so, Susie, I was wondering if you could help us think about kind of the elements of multidisciplinary care and how important that can be in the treatment. And frankly, not even the treatment, but the working with an individual with dual diagnosis.
Kristen, I have been so fortunate over the last 15 years to be involved in a multidisciplinary team. And it has taught me so much. Sometimes as a provider, we come in with our expertise, and I know a lot about mental health. And so everyone should listen to me, and I have the answer of what it is that we're going to do for this child. And yet, there are other people sitting at that table with me who have as much expertise as I have, only in a different area. And so one of the things that I have learned is to listen to other people. John mentioned it, Shauna mentioned it, that we sometimes pigeonhole individuals, and this is the silo that is going to treat them. We miss out on so much if we don't bring everybody to the table. I think sometimes I've been in some heated discussions with other providers because I'm right. but I'm not always right. Yeah, and I guess one of the things I was thinking of recently, and maybe this comes with age, is that we're always trying to get people to change. When someone comes in mental health, here's the plan. I'm working with parents. Let's look at the treatment plan. Here's the plan. One of the things that I have learned, I have to change too. The providers have to change too. I have grown so much by listening to other experts in other disciplines than mine, because you can treat that whole child, when you bring all of those people together. I think the other thing with that, and in your first example, thinking about the rural, and that clinician who's out there by themselves, and I'm thinking, oh no, I'd hate to have to go back to that, and yet I think, Kristen, what you have done, what others have done, like with our ECHO, is we've brought experts together from all over the state, and at times I've been on an international call. You've brought people from all over the world, together. And so even though you may be in the most rural part of Missouri, you don't have to be alone. And so that there's a way to get that interdisciplinary team wherever you are, but you have to reach out for it.
Yep, I love that. I mean, I think that's such a powerful thing. And just really, I resonate with a lot of the themes that you shared, which is humility, right? So being humble enough to accept that other people know things you might not know. And I agree with you. I'm also often in that camp where I'm like, I know I'm right, but whatever. But honestly, though, that's not true, right? I learn from people every day. And frankly, so often I'm learning from my patients themselves. I'm learning so much from them and from their caregivers. And I think that humility in practice is so important, but then that teamwork is just as important, right? And I love the highlighting of the fact that now within our global world, we do have the opportunity. You may not have an actual multidisciplinary team inside your brick and mortar building, but you likely have an opportunity somewhere to reach across disciplines, if you will, to gain those additional supports. And I think what a great opportunity that is to be able to really provide that best practice care for people, and certainly really important. I'm going to ask a question. Actually, back to Lisa. Sorry, Lisa, I'm really leaning into you today. But I'm curious about your perspective in working with interdisciplinary or multidisciplinary teams. And what would be your advice to other caregivers or people with a dual diagnosis on how to make sure that their voice or their preferences or their perspectives are being heard and included in that treatment plan or in that plan? Again, I'm trying to get myself away from treatment, because to be honest, that has its own icky kind of connotation, right? But like in their own plan for moving themselves forward or their loved one forward. So Lisa, how would you encourage others, or what advice would you give them?
Well, I would first say making sure that the families and the individuals that are there seeking professional help are included in the team. They feel like they're part of the team. Don't talk to them, right? Don't talk at them, talk with them. Show them how to do the things that they need to do. When they feel like they're a part, and again, I'm going to go back to my personal perspective. When I felt like I was part of my daughter's team, I felt like I had a more invested role, right? I knew what I needed to do on my end. And this even goes as simple as an IEP meeting. And I don't use the term simple for IEPs to say that they all are, because they're not, but that's a good example. So, but I knew what my role was. And if they were listening to me and validating my concerns, that's the most important thing. And when I walk away and I feel good about where I am, where my daughter is, where my family is, where we are with our situation, I'm going to be more apt to do my piece. I wanted to know what the therapist, I even wanted to know what words they use. When you're working with my daughter in OT and PT, what terminology are you using to get her to do these things so that I can replicate those things at my house? I think it's important that families don't feel intimidated. When you walk in and you're surrounded in a room full of professionals and you don't feel like you really amount to much, but really, I'm the reason why you're here. My daughter is the reason why we're having this meeting. So I think validating and making them feel a part of and listening is so critical, very important.
Yeah, I completely agree. And I think, really all of us can do that in that space, whether that be the clinician, reaching across and asking the patient, sorry, I'm a physician, so it's hard for me not to think of people as patients, but, and just saying like, tell me, what do you think? Or here's what I'm thinking. I hear what you are sharing with me. This is what I'm thinking, and this, I think one of the big takeaways here is also not making assumptions, right? I think often it's so easy to make the assumption that, oh, that person's minimally verbal, they don't have anything to contribute. Wrong, right? Like super wrong. And so really checking your own assumptions and trying to embrace those individuals that are with you as part of the team are super critical. So thank you, Lisa. That was really helpful. When I'm thinking about, helping individuals live their best lives and really helping all of us, frankly, don't we all want to live our best lives? As we think about that, these positive behavior strategies, I love them. And I think there's so many out there that can really help us move the needle in these spaces. And so I'm hoping that Terry can share with us a little bit about, positive behavior strategies. What are the elements we should be thinking about and looking for? And what would you kind of help us to better understand about that particular topic?
Yeah, I don't get a chance to talk to people much, so you guys are in trouble now. So what I like to think about for myself when I'm thinking what are positive behavior strategies is I really consider each of those words individually important. So positive is important. Positive means building, increasing, strengthening, improving. So positive is very important. You notice it's not get rid of bad behavior strategies, right? It's positive behavior strategies. So we're looking at what does the person need to be able to do in the situations that they're not doing now that would make things better? What do we need to do in these situations that we're not doing now that would make things better? So it's about improving the quality of life, but it's about increasing behaviors, increasing desirable behaviors, much more than decreasing. I don't even know, the scales are completely different. So the focus on undesirable is this tiny little scale that you're going to have to pay attention to, but it's not your main focus. And it's the Statue of Liberty for positive behavior sports, if you will. It's so important. And then behavior, positive behavior support. So behavior includes both inner behavior and outer behavior, or overt behavior and covert behavior, if you will. So thinking is behavior. Feeling is part of the behavior. They may not be, for me, the ultimate cause, but they're part of what I need to consider. So, and also I need to be very precise and very specific. So I'm not going to try to attack a general kind of diagnosis. I'm going to look at specific actions, behaviors that the person does. So it's very important to look at those specific actions and focus on desirable. And then support. So think about what you say when you say support in other areas. What does support mean? It doesn't mean control. Support means make it possible, right? So what if we called it positive behavior, make it possible plans, right? That would be perfect. So what does it take to make it possible for that person to do those behaviors? What does it take to make it possible for mom to follow the plan? It's really about everybody, or the teacher or the therapist, to follow the plan. It's about supporting the whole world the person lives in to get the desirable behaviors that you want. And then a plan, of course, is an organized, thought out recipe, if you will, for actions that everybody has to take in order to get positive behavior change and to support the individual. So I think I consider each of those words part of what we need to think about. And then the elements are, if you're doing those things, you're going to naturally do the elements that are necessary, I think. But you need to be looking at how to improve the person's life and how to improve the person's behavior in those situations that you've found are problematic for everybody. So problematic for the person, problematic for everybody. Sometimes the person's just fine with what they're doing, but it drives everybody else crazy. And so, you know, we have to try to convince the person other things that might be better suited to them. So what are you going to increase and strengthen? You've got to assess, what do they do now? What do other people do that are in those situations? And how can you build those skills? Almost everything is a skill, really, in the person's life. And think about the things that Rachel said in her presentation about how to talk to and modify therapies, because those things are what you're going to be looking for. Small steps, repeated. You're going to identify the problem situations specifically. Don't again go to generalities. Like, it doesn't help me to know that he has tantrums. I need to know under what conditions and what is a tantrum involved. One time I was working with a foster parent, and they were about to give notice on a child that they'd taken in their home because of, I forget what she called, I think she called it opposition or something like that. When I tried to figure out what things were happening that she was thinking was the kid being oppositional, it was that they weren't keeping the top of their dresser clean. And I think that was like her prime example. And I'm sure there were 100 other similar situations that were bothering her, but I would never have gone ever to the dresser's not clean as an oppositional behavior, right? So it really is important to talk about the specific actions that you're looking at. And people hate this, but measurement's important. You need to know where you are now and where you want to go and how you're moving along the way to see if it's working. So that's very important. It doesn't have to be done by the parent, but somebody's got to be looking at that at a frequent interval. And then I think the two most important things everyone's hit on, so I'm going to hit on one of them now, and that is you have to work with the whole team. So the behavior person doesn't just go behind the curtain and do magic behavior stuff, and then the speech person can do whatever they're doing and the medical person can do whatever they're doing. The behavior person has to know and be involved in what everybody is doing, and everybody needs to know what the behavior person is trying to do, and we all have to work together. So it really is about the whole team approach. It's very important, and we all need to communicate what we're doing and how we're doing it. And if I can in my plan, I should incorporate those mental health treatment things in my plan. And if I can in my plan, I should consider those medical issues and make adjustments for them in my plan. So I think that hands-on training for everybody, but especially the people that have to implement the big parts of the plan, is very important. And the person who's doing the training needs to see you do it, you do the plan, and then give you frequent feedback on it. And that has to be ongoing, because behavior drifts just like snow. And we're going to get a storm here soon, so it's on my mind. And so in order to keep us all doing the same thing, we need to have frequent feedback. So
awesome.
Wow, that's a long answer, but there you go.
No, that's great. Thank you so much. I think there's so many different pieces within that are really important. And I think one of the most important things is really communicating across our settings. And so that, I think, is an important thing, especially for individuals who may have additional diagnoses. You know, maybe there's a primary one, but then maybe they have a couple of other things going on. That communication, so whether that be in the form of written communication, where you're sending your notes to a different, you know, to the team, or whether you're actually having team meetings, but that communication is really essential. Otherwise, I'm sure Lisa would agree that it often falls to the family, you know, to carry around a binder or something that has all of that stuff in it. And so definitely pieces that we can be doing as professionals to limit or lessen that load. So now thinking about the role of others, and again, that cross-setting perspective, we obviously have lots of kiddos or adults who may have very significant behavior. And so I really want to ask John to help us think about, when do we start to consider medications in the course of behavior management? And then also, as we're thinking about that, how do we start to think about this individual's behavior in relationship to kind of their identity, or in relationship to their forming identity? And what do we do with all of that? And I know that's a tough combination of topics, but I think it's actually all pretty relevant to each other, because if we are introducing intervention, whether that's medical intervention or behavioral intervention, and yet we have someone who's really still struggling to either form their original identity or having a crisis within that identity, those are all things we need to really weigh and be attuned with. So John, I'm going to turn it over to you to help us think about that.
Sure. Well, just to take a little step back, is just to make sure the audience understands that when we refer to dual diagnosis, we're talking about a primary developmental disability that's accompanied by an impairing or disabling psychiatric condition. Those are the two things that are coming together. And sometimes people talk about dual diagnosis. It can be medical conditions that complicate a developmental disability, and that's true. But our purpose for this group and this work is to wrestle with the very serious issue when a person with a developmental disability is having a behavioral impairment. And if the first thing to do in a situation where there's a crisis or a person is struggling behaviorally that has a developmental disability, I think a good place to start is to invoke your inner Rachel and ask, is trauma causing this? And then to invoke your inner Shauna and say, if I do a head-to-toe analysis of this individual and their village and all the people around them, are there circumstances that are provoking or resulting in this sort of behavior? And what we do in our work and in the app and in best practice, and what we recommend in clinical decision support, is to thoroughly think through that combination of factors that results in a behavioral impairment. And there can be biological factors, psychological factors, social and developmental factors, and I'll try to hit on them briefly. On the biological front, the two most important things to say are that, we know now that some of the biological causes of developmental disabilities are also biological causes of psychiatric disabilities. They actually overlap. The biology of them overlaps. And so oftentimes, some of the biological therapies that we use will address those problems. And it's very important to know, what are all your options? Historically, people did not think that people with developmental disabilities, would respond to treatments with biological therapies in the same way that people with psychiatric disorders. And that's just not true. So first principle is to think through the biological circumstances, the psychological circumstances. Kristen, you talked about identity, and one of the great, psychological and developmental aspects of thinking about why is this problem happening right now, is to think about how that person understands themselves in relation to the world around them. And we all have to develop identity, and we all reinvent our identities as we grow up. First, we base our identities on our family of origin, then our peer groups, then where we fit in the universe. And people with developmental disabilities do the exact same thing. They may not have all the tools to assimilate all the information, or may be difficult to process information from some of it. But identity is all about, am I competent? Am I valuable? And am I lovable? That's what identity is all about. Am I valuable? Am I competent? And am I lovable? And so there's lots of junctures in life when those can be compromised. Competency, for example, is threatened all the time, the sense of competency for individuals with developmental disability, because of limitations that they have, because of people, indicating to them that they're not as capable for certain things as others. And at certain junctures in life, an individual with a developmental disability is going to ask, what do I have control over? For what am I the agent of my own destiny? What can I contribute? And is that of value to other people? And am I of value to myself? And do people, despite my developmental disability, love me and care about me? And you can imagine the different life circumstances and permutations and combinations of things that will threaten that. And so I always, in the psychological evaluation of a person with developmental disability, I'm always asking myself, has something happened where all of a sudden it can be a cue that is picked up by that individual that nobody even knows. Some of the most spectacular existential crises of adolescents with developmental disorders have happened because of things people have told them that they didn't realize what it meant to them. A parent, one of my favorite examples of this, it was a young girl, an adolescent girl, who was reared by a single mother who was actually her aunt. And she always felt like that she was a big burden on her aunt. And one time her aunt had a very significant surgery and needed, help to recuperate from her surgery. And this young girl wanted to do anything she could to finally give back to her aunt. And so she made a meal for her after surgery when she couldn't eat anything anyway. And her aunt was grateful for it, but kind of dismissed it, like, oh, like, I'm just wearing off of the anesthesia. This isn't the time, like, put those things away. Did you turn off the oven? And it destroyed this girl. I mean, until everybody figured out what it meant, that this was her overture to try to come back. So existential crises of identity are all people with developmental disabilities are people first and have a developmental disability second, and not the other way around. So we have to think about that. So the final thing I'll say, Kristen, is that in the biological therapies, it is very common for people to have, well, we tried a medicine and it just didn't work. Or, they told us what the diagnosis was and there isn't anything for that. And the issue is in dual diagnosis that there are biological therapies for some of the most serious behavioral impairments that include disinhibition, mood dysregulation or depression, aggression, either towards self, others, objects. And there are classes of medications and treatments that are so often overlooked in the care of individuals. If you just go down the line for the treatment of aggression, for the biological therapies, a lot of people think that the only biological therapies for people with developmental disabilities are the neuroleptic mood stabilizers, the antipsychotic medications, but that's not true. The anticonvulsant medications, lithium, alpha agonists, anti-anxiety medications, and even certain subclasses of neuroleptics that are very often in situations that are referred to specialty centers where people have just kind of thrown up their hands and said, well, there's nothing else that can be done. Sometimes these aren't tried, and sometimes these are the pathway. So definitely think about those biological therapies. Absolutely, positive behavior supports, as Terry was describing, are so important. And I want to make the point about those, that although Terry said, it's about being positive, totally right, that is the method. But that doesn't mean that those therapies that are positive behavior support strategies don't have valence for very negative behaviors. So the worst negative behaviors can be extinguished with behavior support strategy alone. And so that there has to be no stone left unturned in terms of applying the technologies that we actually have for those supports.
Thank you. That was a really important and powerful comment on how we think about where we start when we're thinking about this person before us. And yes, they are a person. And so I love how powerfully you said that. So thank you for that. And I think the other takeaway that I would really emphasize is the fact that having multiple perspectives on your team to really help to think about what makes sense for this individual is critical. And sometimes if maybe as a family member or an individual with a dual diagnosis, if you're feeling like you're not getting the aspects that you need, then continue to seek and advocate for the people to be on your team. And so really, really important pieces there. So I'm going to wrap us up with a couple of questions that are for the whole team. And so one of them is really thinking about, what do we do when help is available? So help used broadly, but maybe that family or that individual isn't ready to accept that help or isn't ready to embrace that particular kind of help. How do you all think about that? And what are some pieces of advice that you might offer? We'll kind of go round robin on this one. And so everyone can have their own perspective, but we're going to start with Amber first.
So my biggest thing is always being empathetic. and meeting the person or family where they're at. It's really, really hard, like Susie was mentioning earlier, to kind of like, this is what you should do. Like, this is, I'm right. Like, this is where you should be. And kind of taking a step back and realize that person or that family may not be ready for that yet, but knowing that there are certain things they could do in the meantime. So kind of having some of those simplistic, you know, all right, so you may not be ready for applied behavior analysis and have a behavior analyst in there, but what can they do in the meantime that's positive or working towards that? Is there a training class they could go to, a parent training class that's local? Is there a local resource they could reach out to, a church or peer support that might help them feel more engaged rather than going straight to the professional or therapeutic side of things? Like, what can you do? Also, to just knowing what I know, resources tend to be limited too. So even sometimes when the family's not ready, we're not necessarily ready with the resources on the end to provide that service. So how do we help them through that? And realizing that they really need advocates and help along the way. And it's not just simply, oh, go see this person and it's going to be the answer to everything. It's a process and it may take years. And working with them. So being there for that family and that individual is very important.
Awesome. Thank you, Amber. That's really important. How about Rachel? If you'll share with us your thoughts on this.
Sure. You know, my background is as a licensed clinician is to use the stages of change model. When you're trying to understand where someone's at and you have some ideas about how you might get them somewhere else, it's really acknowledging they might still be in pre-contemplative or contemplative stage of change while you're over here in the action stage with your care plan already bullet pointed out. And I think along with that is just acknowledging the ambivalence that so many people feel about, yes, I know it's important and I need to do this, but I also feel equally strong that I'm not going to do this yet. And just be able to sit with people with that, especially when it's dual diagnosis cases. Lisa so eloquently illustrated how this impacts families. So when families aren't ready for change yet, we just need to be able to sit with them and be okay with that and help them figure out what would it take for you to be ready for change, but not shame them that they're not ready yet. So I'd say using that stage of change model, because it can be so broadly applied to many of all of us on the call today and changes that we might be needing or wanting to make in our own lives.
Great. I love that. Thank you so much.
Can I offer just a slight qualification that I think is important? And
yes, go
which
for
is
it.
one of the things that happens to this group of families is analogous to what we describe for individuals who are depressed on the basis of learned helplessness. In other words, they may come to the table not really knowing what they want, but believing that no help is available and having learned that even when they try, it never works out. And I think what Rachel and Amber said is absolutely true. You know, we have to meet the families and the patients and the clients where they're at. But I also think one has to take into account that sometimes where they're at is in a place where they have been put into that box. And when you know that that's what's happened and that they have adopted that kind of resistance on that basis, there are really ways to help them out of that, but only if you're taking into account, not just to take at face value that they're not ready, but the reasons that they're not ready. And so it really behooves all of us to really think carefully about why they are there in that particular juncture.
I think that clarification is incredibly important because you're absolutely right. So it's meeting them where they're at, but then also building that shared relationship or that parent, professional, caregiver, professional, individual, professional partnership so that they start to gain that, I'll go with alliance, right? Where they know that you are there to work with them and work alongside them, as opposed to like, I love the word shame that you used, Rachel, because I think that's so often, unfortunately, what happens. It's like, well, what do you mean? Well, do I need to, take steps now because you're not doing what I told you to do? Right. Rather than, again, using that compassion, that embracing curiosity to really figure out, like, where are you? How can I help you get to the goals that you think are important? And I think that's a really important piece. So thank you both for that. That's really, really good information. So let's see, Susie, if you would, oh, Lisa, go for it. Yes, Lisa, and then Susie.
No, I would just add that, a lot of times you might see a family come in, but you might be their 10th person of the day, right? So the overwhelming, if you can help families break down, okay, so Dr. A said this, Dr. B said that, therapist C said this, and oh my gosh, and I've got to go home and put this all together. Realizing that overwhelming feelings where they're just inundated with all the stuff, and then helping them break it down. I think if somebody can say, hey, it's okay, take baby steps, we're going to get through this. It might not be what you anticipated, but it's going to be okay. It might look a little bit different, but we're going to get through it, right? So that assurance and helping them just break it down into smaller baby steps, I think, is very, very important. And like Dr. Constantino said, there's a barrier for them. It could be a variety of things. It could be that they may have just lost a loved one a few weeks ago and just can't get to that point yet. So yeah, making those assumptions, it's hard not to, but I think it's critical that we don't.
Yep, I agree, Lisa. Thank you for that. Susie, what would you add to this conversation about helping families, just feel supported, and even if they're not quite ready to accept what's going on, kind of how do we keep supporting them?
I always think about the relationship, and how I can join in that relationship to be supportive of them. It's easy sometimes for me to come up with this list, and yet I'm not living in their shoes 24/7, and so I've just asked them to add 3 more things, and they're thinking I can't do it. So some of that is being really aware of what support the family needs to be able to make that next step of change. I think just kind of helping to walk alongside of them, and sometimes a phrase we've used in our clinic from time to time is what's the biggest rock that we're going to start with? So we're going to do one thing, and which of these do you think that would be the thing that you could work on? And maybe it's the smallest rock, but we're going to do one thing instead of, it's a step-by-step process. I guess the other thing, and I have learned this from Lisa and from other families who have walked through this, is that peer support. Sometimes it's not me as the provider that can make those recommendations, and the family go, yeah, I'm going to do that. It may be someone who has done that and has been able to see, what did I need to do? And hey, it really did work, and so looking at all kinds of support for this family.
Yeah, absolutely. Very, very well said. All right, Terry, you're up next. What would you add to this conversation?
Everything that everybody said, I agree with. Break it down, break what you want them to do down into its smallest parts. And instead of presenting, write your dissertation, present, find an article that you find interesting on this topic. So that's an academic example, but that's really how I got started to finish this horrible thing called a dissertation, which was bigger than anything in the world I'd ever done. And it's the same thing with moving or buying a house or choosing your daycare. All of those are huge tasks, and you just got to find out what's the first thing that you can do or you're willing to do now. And why don't they want to have behavioral services? Why don't they want to have somebody in their home? They may not tell you, but it doesn't hurt to ask and listen to what they say and figure out what maybe they had something that they think is what they should do, and we haven't asked. Like, well, okay, what do you think you should do? Is that a workable thing? Can we work around Okay, I think I should, find a job first. Okay, let's work on what you think, unless it's counter therapeutic, but it doesn't hurt to ask. So those are the things that I would do. And I would keep communication open. So a lot of times when we're talking to teams, we hear, yeah, they don't want to do that, or they don't want someone in their home. That was last week, maybe not next week. So keep that communication going.
I 100% agree with all of that. So we're going to be wrapping up our time together. And I do want to have a chance for Shauna to also share her thoughts about this particular question, really about how do we support families who are at different stages of readiness. So Shauna, what would you say? Like, you work with families all the time. And what would you say to that type of family, or to this type of person?
I mean, I totally agree with everything everybody said. I think it's building that relationship, and we have to understand as providers that our recommendations or our desire for them to do that doesn't necessarily blend with their current status of coping. Like Lisa said, it's all a process. I work with families every week who are newly diagnosed little bitties with autism, and you blah a lot of information to them. And I always say at the end, I know I've told you a lot. Here's my phone number. I want you to call me when you're ready to have questions, because they don't always have questions at that time. I think building that trust, which takes time, and although frustrating for us because we always get the phone calls, well, why aren't you doing that? Because they're still coping. They're still trying to wrap their head around these hopes and dreams that have now changed for their person. And that's hard. And so I feel like, I mean, Dr. Soul, you and I have known each other for years. My compassion for families is what drives me every single day. And I think that the relationships you can build with these cause that trust to form. And then they were knowing that what you tell them is not because that's what you do as a nurse, but that you respect them and you want them to be able to help their child for them, not for us, for them. And I think that is key to anything moving forward. And we also, and the one last thing I say is that some of our families, we might not know where they are developmentally or intellectually as parents. They might need more supports. And if they say, yes, I'll go do that, and then they get stuck and they're too fearful to call. So use your social workers, use your support staff to help them. And I just, it's building that initial relationship and that continuation of that relationship over time that helps make sure that these processes and recommendations are followed through with.
I couldn't agree with all of you anymore. And I think that's such an important piece. I do want to thank all of you for sharing your content expertise with the great wide world who's going to watch this. But I think a couple of pieces that I want to leave everyone with is just thinking about how important it is to think about that person first, what they have to offer, what their skills are, what they're valuable for, what makes them count as a person. We all have things that make us count as a person. And sure, as professionals, we want to help come alongside people who may be having challenges and help them, do something differently or better or whatever. But at the end of the day, it is still about that individual. So today we've been learning all about dual diagnosis, that developmental and intellectual disability side of things that starts to merge with behavioral health issues. And certainly I think we can all agree that our brains are not disconnected from our bodies. And so really it is all one. And as we think about human beings and the human condition, there's lots of different things that can be going on within one individual. And so certainly hope that this time together and as you've listened have been helpful to you and helping to understand different aspects of what dual diagnosis means. If you want to learn more, there's great content available on the Department of Mental Health in Missouri's website. But we also have this phenomenal group that meets a couple of times a month called MOADD ECHO. And you can certainly find out more about that as well. So those are generally for clinicians, but it's not closed. So if you want to come and learn more, have at it. You can sign up for that ECHO at echoautism.com or .org /MOADD. And so we certainly appreciate this team's time and frankly, their lifetimes worth of dedication to people in our state, but all the way around the world. So we thank you very, very much for your passion and your time. So we'll end our time together and we appreciate you. We'll see you soon.